Advanced hemodynamic management is crucial for critical care pharmacists. Understanding cardiac output, systemic vascular resistance, and preload is essential. Pharmacists must optimize fluid resuscitation, vasopressor, and inotropic therapy to stabilize patients. Tailoring interventions based on hemodynamic parameters ensures effective shock management, improving patient outcomes in acute care settings. In acute care settings, effective shock management hinges on understanding pharmacotherapeutic principles. Critical care pharmacists must assess hemodynamic parameters to tailor interventions. Key strategies include optimizing fluid resuscitation, vasopressor selection, and inotropic support. Evidence-based pharmacotherapy is crucial for managing distributive, cardiogenic, hypovolemic, and obstructive shock, ensuring patient stability and recovery. Understanding shock types is crucial in critical care. Shock can be classified into hypovolemic, cardiogenic, distributive, and obstructive categories, each with distinct pathophysiology. Identifying these types aids in targeted management, ensuring effective treatment strategies are employed. Pharmacists play a vital role in optimizing therapy, dosing, and monitoring to improve patient outcomes in these complex conditions. Shock is categorized into 4 types: hypovolemic, cardiogenic, distributive, and obstructive. Hypovolemic shock results from blood or fluid loss, such as hemorrhage or severe dehydration. Cardiogenic shock involves pump failure, often due to myocardial infarction. Distributive shock features pathologic vasodilation, seen in septic shock. Obstructive shock arises from mechanical obstructions like pulmonary embolism. Hemodynamic monitoring is crucial in shock management. Key parameters include maintaining a mean arterial pressure of at least 65 mm of mercury, assessing heart rate and rhythm for cardiac function, and evaluating central venous pressure for preload status. Urine output should be at least 0.5 milliliters per kilogram per hour. Lactate clearance is vital for assessing tissue perfusion and guiding resuscitation effectiveness. In shock resuscitation, administer 30 milliliters per kilogram crystalloids within the first 3 hours for septic shock. Maintain a mean arterial pressure of 65 millimeters of mercury to ensure organ perfusion. Address the primary cause while providing supportive care. Monitor for complications like fluid overload and pulmonary edema. Norepinephrine is the first-line agent for septic shock, offering potent A1 adrenergic activity with balanced V1 effects. Vasopressin serves as a second-line addition for refractory hypertension at a fixed dose of 0.030.04 units, (min). Epinephrine is a third-line option for additional support, while dobutamine is used in cardiogenic shock with low cardiac output, providing pure V1 adrenergic stimulation. Pharmacists play a crucial role in shock management by selecting appropriate vasopressors based on the shock type and hemodynamic profile. They ensure proper titration, verify drug concentrations, and assess intravenous compatibility. Adjusting doses for renal and hepatic impairment is essential, alongside implementing safety protocols to prevent errors with high-alert medications. A 54-year-old male presents with septic shock, mean arterial pressure at 55 millimeters of mercury, lactate 4.5 millimoles per liter, and low urine output. Pharmacists confirm crystalloid administration, initiate norepinephrine to achieve mean arterial pressure, 65 millimeters of mercury, and consider vasopressin if needed. They monitor urine output, lactate trends, and adjust renal dosing as kidney function evolves. Accurate shock classification is essential for effective treatment, enhancing patient outcomes. Norepinephrine is the preferred initial vasopressor for septic shock. Early lactate clearance is a key survival predictor. Pharmacists play a vital role in ensuring medication safety and dosing accuracy. Continuous hemodynamic reassessment is crucial for optimizing therapy and minimizing complications.